Hello, everybody. Reagan Archibald here. Let's talk about treating and examining orthopedic conditions because this can be one of the most challenging aspects of your practice if you're not looking at things from more of a holistic perspective. So, one of the first tests you're going to do is what we call the new reflex test. So, simply pull out a gun, aim it at your patient, pull the trigger, and if the patient ducks, you know you're in the right category as far as reflexes go. Now, I'm joking, don't do that, but all right, so so let's talk about orthopedic conditions. So one of the biggest things you want to do is you want to start developing x-ray vision on your hands. A lot of us have moved away from trusting our hands and our ability to diagnose and understand what's going on with somebody's joint structure because we have technology called x-rays and MRIs. And as we get into the spinal diagnostics, you'll see that sometimes MRIs and x-rays are not always the most reliable source. I mean, people can have bulging discs for years and it won't show any symptoms. Or they can have symptoms of radicular pain or severe low back pain, but they can't isolate. There's nothing that shows up in an MRI or an X-ray. And so, when you're looking at patients who are wanting a different alternative for their condition from drugs or surgery, then you're going to want to look at the entire health of that joint. So here's just some overview. You want to have the patient actively move the full range of motion in each of the joints. Watch for any decreased or increased movement of the joint that's bothering them versus the side that is normal. Always, whenever you're going to examine a patient, you always want to tell them, here's what normal range of motion looks like. Your neck, your chin should be able to go all the way to be parallel with your shoulder. Yours only goes about half that distance, so that's a problem. You want to push on the place where they feel pain. You actually want to touch their neck. Where do you feel pain? Is it number one, number two? Where is the most intense area? And really start isolating where their pain's coming from. And then once you can isolate where that pain's coming from, you can start to see if that makes their range of motion any better, any worse, if that increases their pain, decreases it, whatever it may be. The watching for pain with movement, it's really important that you look for referred areas. So maybe they're having pain down into behind their knee, for example, or under their gastrocnemius, but that pain could be coming from a nerve up top. Maybe their sciatic nerve is being pinched by their piriformis, for example. Listen for crepitus or any popping in the joint. We get really good, especially at your stem cell lunches, when you're doing lots of examinations in a short amount of time. Remember, we're not diagnosing, we're not treating any particular condition with stem cell therapy. So it's actually much better for you to just observe the overall health of a joint. Your job is not to get a particular disease pattern isolated. Otherwise, your liability becomes much higher because you are actually treating something with a natural substance. So all you want to do is listen for crepitus, listen for popping. So you use your common sense in judging what's going on in that joint. And of course, if you feel like that joint has no mobility, no range of motion, if there's nothing to work with, then I always let the patient know. I'd say, unfortunately, I don't know that you're the best candidate for this. I hate to tell you you need a knee replacement, but you can, your range of motion's like it's stuck. It's barely half of what it should be. And, patients don't want to hear that. But at the same time, I always say, we're happy to do the treatment for you, but I can't, I just don't want you to have any false expectations. And, you'll be surprised. A lot of patients decide they'll move forward on it, and we do the injections. They actually get really good improvements. So listen for that crepitus, that popping. I always tell patients, here's what I think is going on in your knee, or here's what I think is going on in your shoulder. And I can't tell you 95% accuracy of what an MRI or an X-ray will show just by listening to the joint, understanding what anatomy is moving a shoulder in a certain direction, or a knee, or a hip. So all those things are critical. So, study your anatomy, get deep into that. And then you want to watch for abnormal movements. I mean, if someone's fingers are locking up, or if they get to a certain place and their joints more prone to pop out, if a knee's more likely to hyperextend, you want to start looking for all those things. Next thing you want to do is just passively do the range of motion. So once again, they're not doing this, you're doing this for them. Looking for pain with the movement, any crepitus or popping, any decreased or increase in movement will be important. And then finally, you want to start palpating the structure. Now, palpate for swelling, palpate for warmth. And each area is going to be important for you to start palpating so you can see if there's any referred issues. So if someone has neck pain, but it's actually their rotator cuff, you absolutely will want to know that before you start treating their neck. You may be missing the entire area that they actually have the pain in. So I never just leave it at one area. I'm always looking and I'm assessing all the joints in their body, and it's pretty phenomenal. Most important is evaluating their spine. So many patients come in, and we're all in this world of technology, having our cell phones, addicted to computers and Snapchat and Facebook and LinkedIn and whatever it is. But here's what you want to look at. So sway back. Does someone have a sway back? That's going to be a lot of instability in the SI joint. It's also going to create a lot of gluteal tension, and piriformis tension in some cases. Lumbar lordosis. You can see this guy's got kind of a little gangster lean there going on with his lumbar spine. So you want to be evaluating this because what is that going to be compressing? It's going to compress on the posterior discs. It's also going to lead to facet joint syndrome, massive amounts of degeneration, thoracic kyphosis. I mean, that's your weight, your center of gravity is being pushed forward. That's putting more tension, more compression on the anterior part of the discs and the thoracic spine. This can lead to thoracic outlet syndrome. So if someone's got this posture and they're complaining of pain radiating into their arms or numbness and tingling, don't mistake this for carpal tunnel syndrome. It's probably thoracic outlet. If their head's pushed forward, once again, that's going to put a lot of pressure on their anterior part of their discs. It's going to cause degeneration. The other thing that you'll find is for every inch that your head's forward, they're going to have so much more pressure. I mean, if you look at it, we'll jump to here real quick. If you go forward 15 degrees when you're looking at your phone, for example, that puts an additional 27 pounds on your neck. 30 degrees is 40 pounds, 45 degrees is 49 pounds, 60 degrees adds an additional 60 pounds. So when you are assessing your patient's overall posture, you want to be aware of that because you could treat somebody's knees or their shoulders or their hips, and if you're not correcting their entire spinal alignment, that's going to be a problem. So fortunately, many of you are working in a chiropractic clinic or you do chiropractic work yourself. That's going to be really helpful. Many of you do acupuncture, and if you do structural alignment acupuncture, you can change a person's entire condition. Good posture is when you can have a line that goes up through the heels, in through the greater trochanter, up through the middle of the shoulder, up the ear. That's the perfect line that we're looking for. You want to talk to your patients about how they're lifting, how they're moving their body, because all these things are going to be critical for the stem cells to actually grow and proliferate. I like to, put my patients, you can have a line you can draw to see how they're doing. You can get 2 scales. That gives you a really good idea of how that person's overall structural alignment is. But look for the patterns of distortion. You can see this lady, her right hip's contracted, right shoulder's contracted down, right hip's up, right shoulders down. So that's what we call a right pattern. And those patterns, if not corrected, are going to diminish your returns. You're not going to have as good of results as you would otherwise. So let's jump into treating the knee. By the way, this is an ancient description of acupuncture. One of my teachers was a famous acupuncturist named Sawada Ken, and this point he's needling is stomach 36, and it helps with all types of autoimmunity in the body. If someone has low white blood cells, this will increase the white blood cells. It's also a good point for pain and endurance. So one of the things that you want to look at is, of course, you're checking the range of motion. So we're jumping into knees. educate on stage 1, stage 2, stage 3, stage 4 arthritis. We'll jump into that just a little later. But if you look at stage 1, stage 2, that's where you have moderate, maybe stage 1 is about 10% loss of cartilage. Stage 2 is when you're closer to about 20 to 30% loss of cartilage. You'll start to have a little bit of osteophyte formation in stage 2. Stage 3 is when you've got a little more degeneration. You're creeping into about the 30 to 55% range. And then stage 4 is when you've had a 60% loss of normal cartilage growth, normal function in that knee. So when you have 60% of the cartilage that's gone, that's when you get massive osteophyte formation, and that's when the cartilage goes into rapid degeneration. So most of our patients, they don't really understand that there's different stages of arthritis, and just because somebody doesn't have knee pain does not mean that they don't have arthritis that's already built in, because it's not until stage 3 or stage 4 when that arthritis builds in. And so we have a whole YouTube series and podcast on just knee pain. And so I would encourage you guys, we've uploaded it in the marketing section of this trainings, and you guys can actually hear me explain and educate people on knee issues. You want to talk to your patients about nutrition, and once again, go to the nutrition piece in your module, the lifestyle and nutrition, and you'll hear all the things with the ochratoxin A and any mycotoxins in food. Getting them off the 3 main killers for stem cells is going to be gluten, dairy, and you guessed it, sugar. So if you can get them off those 3 things, and you're not that interested in nutrition, that's totally fine. Just get them off those 3 things, and they will do so much better. I'm telling you, the stem cell results, why we get the 90 plus percentile range in our overall clinical outcomes, is because we actually talk to them about nutrition. If you're an acupuncturist, you're going to be needling stomach 34 or stomach 36, and stomach 34, gallbladder 34, acupuncture and moxibustion, large intestine 10 and 11, kidney 6. All these are great points for the knees. Biggest thing is, just like we listen to the pulse, you want to listen to the knee. So it's what a normal knee looks like when it's the anterior part of the knee that's flexed. Just to give you a quick rundown, there's your tibial tuberosity, that big old bony landmark right below your patella, head of the fibula. Here's where the knee is extended fully. You want to make sure there's an indentation above the patella. Make sure the patella is not adhering itself. As patients go through further acceleration in their arthritis, you'll start to see that patella does not move very well. And so if that's the case, if you find that there's pain right under the patella, if you can see my cursor right here, if you get pain and experience that right under that patella, then you also, not only injecting into the joint, you can either have a lateral approach or a medial approach. It's up to you, because the stem cells will fill in that entire capsule. Most of the time we go lateral, but if you find that there is cartilage that's worn out underneath that knee, then you're also going to need to inject some stem cells, maybe a quarter of a unit on the medial side, a quarter of a unit on the lateral side, and then do the other half unit in the articulation there. And you'll get great results. If it's a really bad knee, you'll do up to 2 units or a unit and a half. A lot of our patients who their knee has been going on for a decade, you palpated, the range of motion is about 70% or less than what it should be, less than the normal. Then we actually will recommend a unit and a half or 2 units, and we'll just let them know, let's see how much growth we can get in your knee over the course of the next 60 to 90 days. We'll see what your pain levels look like, and then we may want to re-inject it either 90 days or wait the full 250-ish days before you re-inject, so they get the full growth out of the original stem cells. But usually if they get to a certain marker, like at 3 months, and they're not noticing, they plateau on their progress, that just means all the stem cells got used up, and we need to do further injections for them. Also, what you're getting is the cytokines and the growth factors massively decrease inflammation. The proteins that cause angiogenesis will bring new blood circulation into the knee joint. And the environment that's created from the growth factors is perfect for the stem cell proliferation. And once again, we're using 1 unit, 1.5, sometimes up to 2 units. If somebody's got a medial collateral damage in their MCL, you're going to want to inject on that medial collateral. If they've got any of the pes and serine bursa, then you want to inject into that bursa. Usually a half a unit is great for that. Any MCL issues, you want to do a half to maybe a unit and a half. Lateral collateral, once again, it could be a half a unit if it's minor. Usually a unit is sufficient. In some cases, a unit and a half. So some of the things that you want to look at when it comes to the knee, just so you have a good concept. Now, I'm just brushing over this. We could spend a whole day just talking about all the cruciate ligaments and the menisci and everything that keeps that really cool joint in place. But I'm just going to give you a brief overview. First of all, the MCL prevents the knee from buckling inwards, so that valgus injury. So when you push on somebody's knee on the lateral side, have them keep their foot stable, if that causes pain on the inside of their knee, you know that they probably have some MCL issues, and a lot of people do. Now, a lot of snowboarders here in Park City, they have a ton of this. The lateral collateral ligament, the LCL, it prevents the knee from buckling outwards, or the varus injury. So once again, push on the inside of the knee, make the knee go out. Or the other thing you can do is have them dangle their foot off of the table so they're sitting down, and then you want to put your hand on their ankle and have them push their ankle up like they're kicking a hacky sack, and then go the opposite way and see what type of stress that puts on the knee. And once again, whenever you're examining a knee, you want to have your hand on it the entire time. Here's another assessment you can do. You can just have a patient lie down, and you can just put some pressure on the outside of that knee while you're putting the leverage is going on the ankle. So let's say you're examining their right knee, and you're seeing if they've got a collateral ligament issue. Then you would just put your left hand on the outside of that right knee. Your right hand goes on the inside or the medial side of their right ankle, and then you just put a little pressure there. And then the opposite is going to be for the valgus stress test for the MCL. So lateral, you would do the opposite. This is the medial test here, the medial collateral ligament. Medial cruciate ligament. So here's various tests for the LCL. So if you're looking at the lateral collateral ligament, this ligament that runs right through here, and then here's the medial collateral. Sorry, that was not the medial cruciate. This is the medial collateral ligament. So you're going to put pressure on this. With the varus stress for the lateral collateral ligament, you're going to, once again, if you're examining the right knee, you're going to put your right hand now and push your hand on the medial side of the knee out. You're going to push it lateral while stabilizing that ankle. So your left hand is actually on the right lateral malleolus of that patient. Here's what you'll find if you see you want to look for any growths, so a Baker's cyst behind the knee. We've injected one patient out of Baker's cyst, and she did incredible. She actually canceled her joint replacement. She was so happy. And then she went to her doctor, and her doctor injected alcohol into that Baker's cyst, and all of a sudden it was like everything died. And her stem cells just quit working altogether. So don't inject unless you get rid of the Baker's cyst, and even getting rid of it, it grows back in most of the cases. So just be aware of it, that it's there, but tell your patient, do not inject it. She didn't ask us at all, so it was a problem. All right, another big problem, osteoarthritis. More than 40 million Americans have this. And it's going to be a big problem in the future, because in America we're getting fatter, and half of the U.S. adults have some type of of overweight. 66% of obese adults will develop painful arthritis by the age of 85. And then the interesting thing about it is, for each pound of weight loss, there's a 4-pound reduction in the forces hitting your knee while walking. So this is from Arthritis and Rheumatism back in July of 2005. Here's what the normal cartilage will look like inside of the knee. When you have advanced arthritis, this is stage 4, you're going to have inflamed tissues, and then you're going to have exposed bone. So that's why we're listening to that. Most common imaging for confirming osteoarthritis is typically x-rays. Cartilage does not show up on the x-ray, but the cartilage loss will be revealed because there'll be a narrowing of the space between the bones in your joints. So you'll see some of these coming up here that will look kind of like this image, where you can see the healthy knee. There's nice space there in this x-ray. The bald tire effect is when that is bone on bone. Bone spurs. You can see bone spurs around a joint. You got to be careful if you're injecting those. I mean, most patients are going to have some small osteophytes, some small bone spurs built up there, and we find that that's typically not a problem. The growth factors can, and the cytokines will decrease those bone spurs in smaller cases. If it's a large bone spur, then you may want to recommend that they see an orthopedist and get that bone spur removed before you do any injections in there. But once again, the x-rays is going to show osteoarthritis even before patients experience symptoms, but not in all cases. So here's kind of the stages of arthritis that we talked about: the stage 1, stage 2, stage 3, stage 4. And you can see stage 4, once again, that's where the joint space is greatly reduced. 60% of the cartilage is already lost, and you'll typically have large osteophytes. So just see how large they are. If the patient has full range of motion in their knee, and if there's nothing causing it to lock up, but they do have stage 4 and some fairly large osteophytes, it's not a problem typically. So, just let your patient know this could be a problem. But, if that patient's 85 and they're very fragile, or they're sensitive to anesthesia, or they can't tolerate a local block, then, this is their only hope. So, do what you can. But you want to make sure that you're getting probably 1.5 to 2 units if there are large osteophytes that you don't feel comfortable, or the patient doesn't want to get removed. Do the strength testing. You want to just compare their strength with their knee flexors, their quadriceps, and hamstrings. But that's going to be key. So you can test with the patient in seated position, knees bent over the edge of a table. Just ask the patient to extend and straighten the knees. You'll see me doing some in our videos where our patient Brigham, we'd go through all this. So ask the patient to flex and bend the knees against your resistance, compared it to the effective knee. Here's kind of an interesting study: the arthroscopic partial meniscectomy versus sham surgery for degenerative meniscal tear, in a randomized double-blind sham-controlled trial in 146 patients 35 to 65 years of age who had knee symptoms consistent with a degenerative medial meniscal tear. In this trial, this is the number 1 most common surgery in the United States. Averages about $9,000 to $25,000, depending on the complexity of this procedure. In this trial, patients without knee osteoarthritis but with symptoms of degenerative medial meniscal tear, the outcomes after arthroscopic partial meniscectomy were no better than those after a sham procedure. And that was when they measured the outcomes. In the beginning, they watched the patients over the course of a year. In the beginning, the group that got the surgery, they actually outperformed the sham group. So sham surgery, just you get the incision, you don't know if you got the surgery or not, it gets stitched up, and then they just watch you. And then the group that did not get the surgery, didn't fare as well initially as the group that did get the surgery, but then at the end of the year, the group that got the surgery was actually, they had much faster rates of degeneration than the group that did not get the surgery. And so it's actually, in the long run, your patients are safer not to get the meniscal repair. So here's some questions you want to ask your patients in your examination. So non-contact injury with a pop, that's usually an ACL, your anterior cruciate ligament. If they have a contact injury with a pop, that's going to be more the MCL or LCL. That's a tear typically. It could be a meniscus tear or it can be a fracture. If they can't put any weight at all on it for more than about 5 steps, there's probably a fracture there. If they have acute swelling, then they could have an ACL tear, a PCL tear, a fracture, a knee dislocation, patellar dislocation, lateral blow to the knee, MCL tear, medial blow to the knee, LCL, lateral collateral ligament. Knee gave out or buckled, that can be an ACL tear or a patellar dislocation. And then if they fall onto a flexed knee, that can be a PCL tear. Now, most of the patients who come to get stem cell therapy, they're not coming for an acute injury. So you need to rule that out. They're typically coming because they have a chronic condition. But if you can go back to and trace their history, then that will help you in your examination process so you can really get a good picture of what's going on. So if they've got cartilage injury, if they've got the arthrosis of the knee, you just want to see what type of functionality, and then you also want to look at all the other ligaments so that when you do regrow some cartilage in there, they have stability in that ligament. If your patients have had cortisone injections, you need to wait at least 30 days, maybe 6 weeks. But what you'll find is this: if you look at them under a microscope, once someone's been injected with the cortisone, it looks like battery acid got injected into there. And so you'll see they'll have a loss of bone mass of 8% in 4 months. Low doses can cause cataracts within a year. Now, I just had a patient at one of my events. He said, "You got to be kidding me. So that causes cataracts?" And I said, "Yeah." So we try and help people avoid the cortisone injections. And he said, I got cortisone injections in my knee 6 months ago, and now I have cataracts. And I never had any type of issues with my eyes before that. And yeah, he was a little miffed. Elevated blood sugar. You can send your patients into a diabetic stroke, so that's a big thing. Suppressed ability to fight infection. Those are all big things. And most of our patients are going to be on NSAIDs, so the other thing you want to make sure they're off of before you do any injections is any ibuprofen, Celebrex, naproxen, all those heavy hitters. Tylenol is okay, but almost everything else, you just want to make sure that they are not there. They're not taking the NSAIDs. That will block the ability for the stem cells to proliferate. Joint total knee replacement. I mean, we've helped almost 400 people to date avoid total knee replacement. And I love that because, first of all, it's a very risky and dangerous procedure. But second of all, there's nothing we can do. I mean, if stem cells don't work, it's not fun, and we don't like to see that. But if it does work, great. But if it doesn't work, then they can still get the knee replacement. But once someone's had a knee replacement, it's not like we can go and inject stem cells and regrow that joint. We can help some of the surrounding tissues and ligaments, but we can't get them that joint back. And about 50% of people need additional surgery, and it's a very painful process. So hopefully that helps in the examination of the knees. You guys have heard me talk about some of the incredible results. If you're looking at regrowing cartilage, once you determine this osteoarthritis, there's cartilage that's worn down. Here's a study that was done. You can see where the stem cells were injected. Before the treatment, they looked at the cartilage, and they could see where there's that massive amounts of cartilage loss. Even the meniscus was pretty worn out. 7 weeks later, you can see on that anterior side of the knee, that cartilage, the black area indicates the cartilage regeneration. It's starting to backfill, and maybe about 30 to 40%. By week 16, they've got about 80% more cartilage already grown in that knee. So pretty phenomenal stuff. Another study that was done back in 2008, they had a meniscal tear. Researchers injected stem cells into that meniscus. You see almost 3 years later, that meniscus tear was completely gone, and the meniscus was still intact. So very powerful stuff. Here's another before and after. This is a load-bearing x-ray. Before the stem cells, it's kind of that stage 4 arthritis, getting bone on bone. It hadn't collapsed entirely, but at different images, just the way the camera is faced, it would show that it was collapsed pretty much entirely. And then 6 months after the treatment, you can see there's nice space in there. So lots of great things you can do with knees. It's one of the most predictable areas for you when you're doing stem cell therapy. This will be very exciting in the future as we learn more and more about it. One of the things you can do if you want to add in more growth factors, more hyaluronic acid, which provides some lubrication in the knees, it's already contained naturally in the umbilical cord tissue or in the amniotic tissue. But the other thing is the Wharton's jelly. So Vera Bioscience makes a Wharton's jelly that is just straight up growth factors and high levels of that high chain hyaluronic acid. So the hyaluronic acid that's naturally occurring in any of these products, these tissues, is about 400 times more potent than the hyaluronic acid that's made synthetically. But even the high chain hyaluronic acid, which is found very densely in the Wharton's jelly, that's about 30 times more potent than the hyaluronic acid found in the amniotic fluid. So add some extra lubrication in there if you need with your patients who are really bad. We've had one patient who had his knees injected 3 times just because every time he gets them injected, he gets a little more cartilage, and he's excited about that, and he wants a little more cartilage and a little more. And so we're just kind of experimenting with him, and we're seeing pretty cool things over the last couple of years. So let me know how things are going. You can send me an email at info@gowellness.com, and let's let me hear your case studies and help you out if you need any help with this. So hope you guys are doing great, and we'll see you on the next video.